So this is January 2025 Journal Club. It's the first Journal Club of this calendar year. I know it's not the academic year, but it's the calendar year. We skipped December, so I'm excited to be back with all of you. And I'm really excited because this is a kickoff for a professionalism series that the Office of Academic Affairs is starting for this early part of the academic year from now through May. And the first two sessions will be actually represented by Lenox Hill, with Dr. Ethan Freed presenting today the Journal Club article that I was excited about on professionalism, a qualitative study, and he'll go over that. And I'm really, really excited to have my friend and colleague, Ellie Chabate, who's from Lenox Hill, from Staten Island University Hospital of Northwell. And Ellie is chairing up or leading up the professionalism committee under the GME team under Phil Roth, who's on this call. And he's established a professionalism committee that Dr. Chabate is heading up. So certainly has a strong interest and connection to the issues of professionalism in medical education. So I'm excited to have Dr. Chabate here as a discussant and Dr. Freed as the presenter of the article. That's how I do these journal clubs. If you didn't remember, there's a presentation, but there's also a discussant. And the discussion is the most important part of, I feel, us discussing what is presented in this article. So I really thank the two of them for being here and sharing this time together. You all got the article if you registered for this. And I think we'll go on from that. I will pin Dr. Freed as he is the first speaker, and we'll be starting us. And we didn't practice sharing your screen, but I'm assuming.
I already checked it out.
Great. Okay. And I will pin you.
I finally got to a meeting before you, Alice.
Good. Okay. Okay. So you are pinned.
Interesting. Okay, well, hi everybody, and I'm honored to be presenting this article to you. I never say no to Alice, and it always pays off for me. So it's good to be here, and it's good to see some old friends and some new friends. And so why don't we move right into the slides? So let's pull it up and we'll go into presentation mode. Okay. And Alice, I can see you on the screen. Can you tell me if you're seeing the slides?
I see the slides. I just want to make sure I'm recording. Yes, I am recording. Thank you.
Okay.
Okay, I'm
So
good.
good. All right. So the name of this article is Professionalism Lapses in Health Professions Training, Navigating the Yellow Card Moments for Transformative Learning. The authors are Sibold, Sheth, and Last, and some others. And this is from Medical Education in 2024. And I believe it was early in 2024. I'm here to present the article to you, and Ellie L. Charabati is here for the discussion. And I'm so glad that Alice said that was the most important part because it takes the pressure off of me. So here we go. So why don't we just begin by just thinking for a moment if you've ever faced a professionalism issue in your workplace environments. And I would posit that if you haven't, then you just haven't been paying attention.
Right. That's why I understand. I italicized and underlined the word never.
So if somebody wants to unmute, I can't see anybody, but if somebody wants to unmute and maybe relay a brief story to us so that we can maybe get the discussion going.
Just to give us a little excitement.
So if I have to start, Alice and Ethan, we've definitely have seen cases like that, and we've been doing that through GME and education. Things that come to my attention, and I think the article will mention that, is the cultural differences and how you perceive an action or a behavior to be perceived as professional, where it is like normal kind of behavior, especially with international medical graduates starting fellowship or residency. So we have seen that, we have witnessed that. What that article, and I think Ethan is going to touch on that, is our perception of that and our definition of that. And that was the kind of the light bulb moment for me when I read the article. I have to say, I have to read it more than 2 or 3 times. A lot of literature there. That's not the kind of article we're used to with numbers or not. But that was really eye-opening to us. Yeah, definitely. We have seen it, and we can, if we open our eyes and we throw a bigger umbrella, like a much more nuanced definition, we see these unfortunately on a frequent basis sometimes.
So I
Uh,
just want to say, related to culture, and then Annabelle, I have had approaches from residencies with residents for me to help with they call it interpersonal communication skills, which really tags on to professionalism issues. And when I work with a resident from a different culture that you're mentioning, whether they're an international grad or they're not an international grad, but just from a different culture, it does come down that part of the behavior is infused into their culture and how they approach communications. So it's a very difficult situation to remediate because you're talking about something that's inbred in their whole life, but it just doesn't work so well in the healthcare setting.
I mean,
Annabelle?
I would suggest it goes even beyond the setting of their cultural lives. I mean, it's generational. There are different generational views. It's even interdisciplinary. I would say that certain health professions and certain medical fields have a different experience of what is and what is not professional. So, and you're going to see that momentarily.
I just want to have Annabella speak in it.
Yes, Annabella?
Yeah. Hello, everyone. Can you hear me okay?
Yes, yeah.
Yes.
Yeah. So to your point, unfortunately, I see this pretty much on a regular basis, only because of the job of being the SVP of Medical Staff Affairs and getting asked to join teams often to help manage some of these unprofessional behaviors. And to your point, sometimes it is a cultural, especially with our international attendings who, or depending on what country they come from, sometimes our teams may feel like they were being abrupt, but it's really more of a cultural thing. Now, that's how they always speak. They're not being mean. It's just culturally, they're very straightforward and blunt. And but then there's also other concerns that we often deal with. As far as like sometimes we've taken in like voluntary physicians that are used to running their own practices, and now they become part of Northwell, and now they're employed, and they're used to sometimes speaking to their staff members in a certain way. And now they have to sort of change because we now have human resources and we don't talk to our team members in certain ways. So there's also an adjustment because prior they had all the autonomy. They were the boss. They could fire and hire whoever they wanted to. And now there's all these other systems in play that wrap around our employed physicians.
Yeah.
And then we get a lot also, to your point, with just interactions between different levels, right? Where sometimes we have older physicians who are used to we'll call it grilling the residents, and just it comes across, sometimes very, harsh. And so, the residents feel intimidated. And so there's this power struggle that we often see with our attending staff.
Yeah, and I would add that there are so many times there's the difference between intent and impact.
Yes.
So a lot of times, people will say, well, this was very serious. The patient was very sick. I had to be very abrupt, and their intent was not to be unprofessional. In fact, they thought that that was an appropriate way to act, and it really takes some certain amount of discussion and negotiation. Donna, you had a comment?
Yes, just unmuted myself. Thank you. And thank you for really allowing me the opportunity to sit in on this. So I represent nursing here, and I will tell you, we see the same exact thing in nursing. The cultural differences, I think, are key to acknowledge. However, I think we have to be careful to accept that as the straight-laced answer for allowing that behavior to go on. And I can remember dealing with one of my own educators who was from a culture, and clearly the way she represented herself was based on her cultural beliefs. But when the perceptions of everyone dealing with her is that she's being condescending and disrespectful,
It's
then there
disruptive.
has to be some heightened awareness to that.
Yep.
We can't just say it's a cultural thing. And we see it all the time in nursing, the same struggles you're seeing. And quite frankly, we see it in the nursing schools when I teach. There's just some of it is generational, I will say that. Sometimes I can't believe some of the things that come out of my own kid's mouth. But so it is generational, but it's what we accept. Culture is what we accept. So I think, from a nursing perspective, we're always careful to not just say, well, culturally, this is where they come from and this is their style. I think when we have people responding to it, we have to be sensitized to the perception of others.
Great.
I'm
And
gonna
you're
take-
going to see in this study that they actually spoke to many different health professions and not just physicians. Let's have one more comment from
And then we'll go forward. Yeah, one more
yeah,
comment.
and then we'll move forward from
A-
Atika.
Atika, did we say that right?
It's Athika.
Atika.
Sorry.
Yeah, that's okay. Thank you. That was close enough. I was also going to mention that I don't have a specific story, but sometimes we're, kind of like, late, old, I guess like old school medicine, it was really like the doctor sort of making decisions and others kind of listening. Now we have more of a culture of like team-based approaches and treatment for patients, including other disciplines like NP, psychology, child psychiatry. So psychologists and social workers. And so sometimes you will see lapses when one discipline may not I don't want to use the word respect, but really it is respect like other disciplines or feel like they have as much to contribute or as important on the team as they themselves are. So, and I'm sure if I rack my brain, I could think of something, but I've certainly
No,
seen.
you're absolutely right. In fact, when we do our semi-annual milestones for our trainees, there's always a sort of a moment where we're trying to decide if a resident is struggling in their communication skills, professionalism skills, or teamwork skills. And there are various, sometimes it can be all three, and sometimes it's just subtle differences between them. Why don't we?
I just want to say one thing to Dr. Ismail. Is that,
Ismail.
yeah. I have a IPEC Grand Round series I've been offering. I've offered about 6 or 7 of them, and exactly what you said comes up. I know the health system's large, but I've already done 6 or 7. I have
Oh,
one next week
yeah.
at 7 a.m. for orthopedics. So what department are you in?
Child psychiatry.
Oh, so I did child
You
psych.
you know us.
Yes, I did child psych.
Yeah.
So we did child psych already. So this is an important concept of interprofessional education and collaborative care is professionalism. So
Mhm.
thank you for bringing that up, and I
Absolutely.
appreciate you being here today. So Ethan, I think you should start.
Yes. So these authors sought to identify factors that that impaired transformations around professionalism lapses in health professions education. So it wasn't so much characterizing what the lapses were. It wasn't so much a quantitative study of whether or not trainees in various health professions are professional, but they really tried to pick out the factors that got in the way of understanding whether or not professionalism lapses had occurred, and then what the response would be to corrections. So it's a very, very specific question. And in order to answer that question, they really had to do a qualitative study. And we're going to discuss some of the factors around how you do qualitative studies and how the results turned out for this group. Just to review, we are talking about professionalism, and professions are defined as occupations that regulate themselves through systematic required training and collegial discipline. Whoops, I didn't mean to do that. It has its base in a very technical, specialized knowledge, and it has service rather than profit enshrined in its code of ethics. This is from a book called The Social Transformation of American Medicine. But I want you to pay attention to the fact that these occupations are systematic and they require training. So this is our trainees who go for 3 years or 4 years or 5 years, and that they really require a very highly technical and specialized knowledge. But also, whoops, I want you to pay attention to the fact that the discipline of our trainees is collegial. It's done in the setting of being amongst your peers and amongst your colleagues. And the other important thing to understand is that professions have service rather than profit as their orientation. So these are important concepts to remember. The Cruzes, Richard and Sylvia Cruz, who wrote probably the big textbook on teaching medical professionalism, they talk about the various attributes of healers and professionals, and then come up with a list of their intersection of competence and commitment and confidentiality, altruism, so there's your service over profit, integrity, honesty, and you can see the features, the attributes that sort of define professionals in health professions. And then furthermore, they talk about the social contract between the profession and the society. So in society, you've got, patients, which is a subgroup of the general public. You have, government institutions and rules, and that sort of represents the society domain. And then you have the profession, which is the individual physicians, as well as organized medicine and organized programs. And there are interactions between the profession and the society. There are expectations and obligations, and these domains continuously interact back and forth between each other. And that also accounts for changes over time. So we've talked about generational changes in our expectations of professionalism, team strategies in terms of our expectations of professionalism. Remember, the practice of medicine has changed over time. In the old days, the Marcus Welby days, you had those singular physicians doing everything. Today, we work in teams, and the expectations are different. So think about medical professionalism as not just a fixed set of rules, but very often determined by the time, by the setting, and by the learners and the teachers themselves.
I just want to mention that Richard Cruz, is the speaker in February, and he is, as Ethan has so well described, the landmark person in defining professionalism, and he's going to speak on perhaps redefining professionalism in light of the changes in healthcare and who our people are. So very interesting.
Thank you. Yes, absolutely. And we're looking forward to that. The I put this slide in to further emphasize that in general, the way that we think about teaching professionalism is through sort of a situated learning. We think about it in terms of sociocultural theory of teaching, where trainees basically observe, their supervisors, and then basically form their behavior from watching others by example. So, in our model of training, which is kind of a cognitive apprenticeship, there's modeling, there's what's called scaffolding, so where teachers can sort of ask provocative questions and seek very specific behaviors and answers. There's what's called fading, where we sort of give our learners more and more responsibility and then slowly remove support. Coaching, a deliberate practice model, breaking things down into steps. But these are all sort of cognitive ways of getting our learners to take more and more responsibility. We often employ things like reflection. What went well? What could go better? And getting our learners to sort of think about their behavior and their practice. Most of what we teach for professionalism is simply observation and imitation. Sometimes we talk about the actual articulation of learned skills. But most of professionalism teaching is sociocultural. They learn by example and imitation. What these authors did was to do a qualitative study, as I said, to determine what some of the barriers are to convincing learners that professionalism lapses had occurred and what ought to be the actions taken. So their methods were that they interviewed 5 faculty and 20 trainees at McMaster University, and you see a picture of McMaster University there. And they used a technique called reflexive thematic analysis. And very shortly, in this technique, you allow the experiences and biases of the investigator to intrude on the interpretation of the data. So the authors would allow themselves to sort of use their own experience and their own biases to interpret the data. And that interpretation can change over time. So it's reflexive thematic analysis. They allowed themselves to change their views over the time that they were collecting their data. If you've taken Alice's ERSD, is that the acronym? ERSD course, she always encourages us to choose a learning theory with which to frame what it is that we're studying. This study used social and transformative learning theory to interpret the data and select the themes. And in a nutshell, social learning theory and transformative learning theory. So social learning theory is learning that occurs in a social context, sort of what we talked about in terms of role modeling and imitation, involves role modeling and teaches attitude and skills by observing and imitating others. That's social learning theory. In transformative learning theory, learning occurs through deep personal change and shifting perspectives, often through critical reflection on a disorienting dilemma. So this is a little bit more violent, if you will, because there needs to be a conflict in order for people to learn from it. So this disorienting dilemma becomes the kernel that people then change their views and shift their perspectives through. So this particular study used those 2 windows to interpret the data. We mentioned that this group looked at more than just physicians. They looked at undergraduate students, medical students. They looked at residents, postgraduate students. They looked at physician's assistants. They looked at nurses. They looked at midwives and they looked at people that were in the rehabilitation therapists, so physiotherapists, occupational therapists, speech and language therapists. Remember, there were only 25 people in the study, so you can imagine there was only a handful in each of these groups, and I'll actually take you through the breakdown momentarily. Now, their methods were to conduct interviews virtually and record those interviews. The interviews were conducted by a health professional and a non-health professional in order to facilitate a safe discussion space and ensure a sense of familiarity with the content domain, but maintain sufficient distance to ensure trustworthiness of the analysis. Neither interviewer rather, had a role within healthcare training, thereby maintaining an objective perspective during the co-construction of the data. So the interviewers were not people who would otherwise be evaluating their learners. They were sort of separate. They were just, they were just there to collect the data, and the data was recorded, and then the team then went through those recordings in order to pick out their themes. I included from the appendix of these studies the actual interview guide. So this is the interview guide for faculty, and I don't think you really need to read the whole thing, but you can see that it was fairly structured. They called it semi-structured because I think what they did was they didn't necessarily go to every single one of these questions, but they sort of let the conversation move naturally. But this is the general themes that they wanted to cover. What constitutes professionalism lapses? How do they define it? Based on their experiences, how are these lapses discovered or uncovered? What's the role of the various players in the equation? And then what should be the goal of remediation when professional lapses occur? This is again for the faculty interview. Can you think of a time when a lapse was poorly managed? Can you think of a time when lapses were well managed, best practices? And then under the transformative theoretical lens, sometimes professional lapses can be seen as identity threatening or disoriented. Can you think of examples where this was the case? So there's that dilemma that is supposed to spark transformative learning. Reflecting on professional lapses ought to be a key to growth. And asking about that. And can you think of examples when the remediation process fundamentally changed a trainee? So again, where the dilemma led to a change in perspective. So this was basically the interview guide for faculty. The interview guide for learners, for medical students and residents and nursing students, etc., was a little bit longer. But it had similar themes. What do they consider a lapse? Are you aware of things that occurred around you? Could you describe them? If you feel comfortable, tell us about your own personal experience. And you see that there's questions about the remedial process. What would make a good remediation? What would make a bad remediation? And then that transformative lens. Can they think of a time when an episode led to a change in perspective? And you can see this is the interview guide for the students. I promised you a breakdown of who was interviewed, and here it is. So we said there were 2 midwives, there was 1 nurse, there were 5 residents, there were 2 physician's assistants, there were 2 rehabilitation specialists, and then 8 medical students. You can see their breakdown by gender, you can see the breakdown by race. And then for the faculty, there were only 5 people interviewed, 3 of them in medicine, 2 of them in rehab, 2 women, 2 men, 1 preferred not to answer. And then involvement with trainees, professionalism lapses, 0 had only 1 or 2. 3 of them had 3 to 9 lapses, and then 2 of them had 10 or more. So I guess that speaks to their experience. So, any thoughts before we move on about the demographics of the participants or the number of participants? And remember, this is a qualitative study. If you have too many, the data is so ponderous that you can't find the themes that you need to find. But any thoughts about the numbers or the mix of different learners or different in subjects?
Ethan, I think it's very adequate. It's a study which is qualitative. So if you're not going with statistical data and p-values to get like a big N number. And when you're doing an interview and self-reflecting on that and including your bias in that, and you're going back to the transcripts for people who are not in a medical field, I think this is like you said, you mentioned the word kernel. So that's like a start of something for you just, to plant the seed and see where it goes from. Again, when I read it, I had to read it multiple times, but overall, I think it was an adequate number. And again, it's a qualitative study.
Donna?
No, I think this is from before. I think Elizabeth.
Elizabeth,
Yes.
Elizabeth,
I'm sorry, I'll take it down.
Oh, okay.
Elizabeth, how
Hello,
about you?
Elizabeth.
Yeah, thank you. I think it's actually very appropriate. I mean, qualitative studies have the nature that they capture really the human diversity, something that you cannot express in numbers. And very often, this is all you got sometimes, right? This is the sample that you got. You cannot make it larger, smaller, whatever. So I feel it's actually very appropriate. However, and we will see how this plays out, right? You would have to speak to all the limitations at the end of the paper anyways. So I'm really curious about how this plays out.
And don't forget that because they, specifically use this reflexive technique, that they were also adding their own personal views and their own biases to the interpretation of the data. So it was almost like having another subject. So, Phil.
Yeah, I just wanted to comment on the race and cultural identity here. So if you look at the breakdown, 2/3 of the population identify themselves as not necessarily indigenous to Canada. And I think a subtle distinction here that might have been helpful is it's one thing to identify yourself culturally or by race. It's another thing to have been raised in one of those places and been very enculturated, for instance, in South Asia, Latin America, Southeast Asia, etc.
Interesting. Good point.
Yeah, that's a good pickup.
Great. Okay, out of time, Ethan, you want to
Yep.
continue? Thank you, everyone.
All right. So, just to give you an idea, if anybody is contemplating doing qualitative study, this analytic team met monthly for a year and a half, just to pick out the themes. The way they did it was they would send 2 to 4 transcripts to all the team members in advance, and then meet for an hour to discuss the themes that they picked out. And then the reflexive thematic analysis came out because things changed over time. So they looked for both semantic analysis as well as latent analysis, meaning that they tried to just pick out the surface meanings of the actual words, but they also tried to sort of interpret people's words as they went along in order to sort of winnie down some of the themes that they came up with. So this was a very, very long process, and when you think about it, it takes a certain amount of time to interview 25 people, and then to spend a year and a half slaving over the transcripts. It's a long process. So that's an important consideration. But here are the themes they identified, and we'll go into these in more detail in a moment. There were 4 themes. Number 1, lapses are in the eye of the beholder, with personal definitions intersecting with institutional and situated norms. Difficulties exist in recognizing and convincing trainees to respond to lapses that are perceived to be minor or subject to interpretation. So here you had learners, and I venture to think that some of this opinion probably came from the learners as opposed to the faculty, where the people had varying degrees of whether a lapse was serious enough to really require an intervention. Oh, these are small things. Come on, that kind of attitude. So that was one theme that came up. The second theme was that the responses to professionalism lapses occurred within power hierarchies, which impacted how trainees reacted to the remediation process. It risked superficial trainee responses to concerns and led to concerns around inequitable treatment about how standards were applied. So I would imagine that a lot of this came from learners as well, that they felt, that they were maybe prohibited from responding in a way that they felt most natural because they were being approached by superiors and people that ultimately would hold their academic fate in their hands. Theme number 3, fostering transformation involves building trainee confidence, agency, trust, and engagement. Focused support and advocacy for trainees can empower and promote agency in tackling disorienting lapses. And I want to show you the quotes from that later on. I found it particularly fascinating that when trainees were given the opportunity to describe what remediation they thought they deserved, that they felt much better about the whole remediation process. And the fourth theme is that perspective shifts involve deep engagement over time, including, but not limited to, self-reflection, structured discussion, and seeking support. So these interventions really require follow-up and lots of support over a particular period of time. This isn't something where you have one cup of coffee with a trainee and then move on and never talk about it again. So these are the themes that were identified. So let's go to the first theme. And the way these were reported were in quotes from the actual interviews. So that's the way I'm going to present it to you. So here's lapses in the eye of the beholder. And responses to the interviews seem to range from blatant disregard to professional standards to gray areas and misunderstandings. This wasn't a professionalism lapse. You just didn't understand. With recognition that professionalism lapses could also simply be lapses in judgment or unintentional actions. So remember, we mentioned earlier, intent versus impact. What somebody describes as just a minor slip of the lip winds up being actually can be a lot bigger. And vice versa. There can be times when an interaction, which maybe was felt by one person to be big, was really not much of a lapse at all. Another quote that comes from these observations: professionalism itself is contextual and dynamic and always changing. One trainee observed, the perception of professionalism comes from your personal background, your cultural background, and what you are used to before entering that space. We talked about generational changes. There's also changes in your role, that students might have a different perspective than residents, might have a different perspective than other types of professionals. Finally, the context-bound nature of professionalism lapses contributed to the challenges in recognizing or acknowledging those lapses, especially when implicit, inconsistent, or part of a hidden curriculum around expected social or communication norms. So the quote here is, sometimes the standards were explicitly communicated, but many times it was informally applied based on social or cultural norms. And those may or may not be articulated, or they may be context or person specific, right? How many trainees that you've counseled for professionalism lapses would say to you, well, you never told me that I wasn't allowed to copy paste my notes. You never told me that I wasn't allowed to tell a nurse to shut up. Sometimes these are things that we feel or that faculty feel should go without saying, but the trainees would have rather have had them said more explicitly. So lapses in the eye of the beholder. Theme 2, power hierarchies shaded responses to professionalism lapses. Here's a quote. We don't really have any kind of ability to advocate for ourselves in the professionalism process, because if you question the professionalism referral, that is in and of itself considered to be unprofessional. So it's a catch-22. If you question that you're being accused of unprofessional behavior, that itself is an unprofessional behavior, according to this trainee. The power dynamics create a defensive stance among students. Here's another aspect of this power hierarchies. Faculty perceived that at-risk students interpreted the discussion around professionalism lapses as personal attacks. It made the student feel that there was an attack on their identity, and hence the response was to protect their identity and their values. Any of you that have taken the MAPIT 2.0 curriculum know the difference between what was it, blame and shame, or something to that effect, where one is things that you do, and the other is what you are, some sort of constitutive property of your character. And sometimes it's hard for trainees to accept being told that a behavior was unprofessional, because they interpret it as being they themselves are somehow bad or unprofessional. So here's a faculty pointing that out. Finally, power struggles also arose from perceived differences in applying standards. For example, the student came back with, well, these are things that the clinical instructor is not doing well, that are not maintaining professional boundaries. So you just bounce back to the faculty member, well, you're also unprofessional. This is obviously the technique that our Congress is using these days, where everybody else is just as bad as everybody else. The other thing they talk about is this really necessary for this office? I personally have seen physicians look up their own charts and nothing happens to them because they are staff. So this is somebody commenting, for instance, on what would be considered a professionalism lapse for one group, where there seems to be no repercussions for another group. Power hierarchies shading the response to professionalism lapses. Are there thoughts or questions about either of those first two themes?
We don't have enough time, Ethan, if you're going to get through.
Okay. So moving on to theme 3, fostering transformation involves building confidence. And this was particularly interesting. The value in creating student agency during professionalism process is important for students to have a voice in the process of addressing professionalism concerns. The trainee notes, they allowed us the chance to speak. It felt respectful. They gave me the benefit of the doubt. There should be a stronger emphasis on really seeing this from a student's point of view and how they can help, rather than sort of punishing somebody for making those lapses, if that is the real goal. So when students were allowed to think about their transgressions and then think about what the remediation ought to be, they felt better about it. Creating a safe environment where students feel comfortable sharing and reflecting builds trust and helps manage the guilt and the shame involved. We need to create a space where students can reflect without fear, and in that environment, they can address their own lapses without feeling threatened. When students feel safe, they're more open to feedback and willing to grow. So that's I thought that was a very powerful theme, and I'm going to use that in my in how we approach our residents going forward. And then the fourth theme, deep perspective shifts involve deep engagement over time, including but not limited to self-reflection, structural discussion, and support. So reflection framed as a key part of the process and the component that contributed to the outcome. The educational aspect is important, really making people understand why the rules are the way they are and having them reflect on them, and then reflect on their own factors is very important. Furthermore, if they cannot reflect on that, then I'm not sure if you can really change or inspire change. Right now, I'm having a big discussion with my trainees about the dress code, and they want to be able to wear scrubs all the time. And there's an expectation that I think patients have, and I think we need to have that discussion over time, and in order for them to see it my way. Discussion was highlighted as an important tool to navigate the process. It was mostly just an open discussion about what we were going to do and what had happened. The whole process was just an open one-on-one discussion. So I felt very heard. So these are long-term discussions and solutions, not just quick fixes. And then finally, accepting help and developing self-awareness were important parts of support seeking. I think learning to be more willing to accept help, because one thing from before my meetings was I didn't need accommodations. I can power through this just like everybody else. And then I kind of learned later that that's not the way to go about things. A big part of my learning plan was figuring out how to better manage my stress and prioritize my health so that it would prevent professionalism lapses from happening. And we see this in the Professionalism Committee for Zucker all the time, all the time. Learning to manage their own lives in this context of being professionals is a huge factor. So, did these themes align with? Did the themes?
I think we might skip this.
Okay.
Because we're really tight on time, and I want to have a discussion.
Yeah, absolutely. So, professionalism formation it faces a widening rift. This is a discussion from the paper as generational norms continue to change. This traditional professional formation was always felt to be transmitted socioculturally. The main theories driving this learning experience were communities of practice and landscapes of practice. Changing norms have caused a widening rift between learners and teachers that requires evolution and recontextualizing the definitions of professionalism, and to do that in concert with each other, obviously. Identifying and addressing professional lapses is complex. We all knew that. It requires nuanced contextual exploration of personal, institutional, and situational dynamics. And we have to promote and foster genuine reflection and dialogue, focus on building trainee confidence, agency, trust, and engagement. Remember, involving the trainees in the process as much as possible made it more real and seem more fair. And then health professions training programs can better support trainees in navigating these situations, contributing to the broader goal of socializing to a professional culture and practice. I'm not going to talk about transformative learning because we've done it quite a bit throughout this presentation. But just to now just wrap things up, why did they mention yellow cards? So yellow cards are often given out in sports where the referee gives a yellow card to a misbehaving player. Much like the umpire issuing a yellow card, professionalism lapses are often embedded within a power hierarchy, as we mentioned. And these power hierarchies potentially limit trainees' ability to engage or respond. Despite these complexities, examples of transformative learning around professional lapses occur because developing trainee confidence, agency, and trust set the stage for the transformative experience. So getting them involved really made it seem fair and real and much more effective. The transformative experiences were linked to deep engagement with professionalism concerns through self-reflection, structured discussion, and focused support. Remember, time, multiple meetings, not just a one-shot deal. And then counterbalancing these threats with a process that both provides trainees support for reflection and dialogue, as well as agency and voice within the process, can increase the likelihood that these dilemmas catalyze personal and professional growth. So that is the paper. So
my
now,
last set of questions that I put up here. Any comments? And Ellie, any thoughts you have as a person deeply involved in professionalism?
and I'm going to stop the share so we can see each other again.
We'll go back
Thank you.
to the
Thank you,
share.
Ethan. Thank you, Alice. First of all, Ethan, as always, amazing job. Thank you very much. You're always, capturing the essence and your way of presenting it. Thank you very much for doing that. And Alice, thank you for sending this article. When I read it, and I said I read it so many times, I came in with like an image in my head. It's like 4 pillars on which you're gonna build that professionalism edifice. But these pillars needs to be always stressed. like you're having like a structural engineer going through, challenges in cases and presentations. So when you talk about lapses in the eye of the beholder, I think about like this saying that say a man never crosses a river twice, because he's not the same man and the river is not the same river. That means with time is, these professionalism lapses or definition change, as always, as the learner or the faculty members. So we need to keep on challenging ourselves, asking ourselves, what biases do we carry inside, inside us as learners, as faculty members in different domains, and how we're going to modify that, how we're going to change the definition. Also, the power hierarchies, he spoke about it. This is very important, that play at the same field. There is always a referee giving yellow and hopefully no red cards, but the referee is refereeing the game. He's not playing inside. He's not playing against any. So he's just making sure that it's fair and everyone is listened and we're following the rules. Fostering transformation, this is very important. This is the third pillar. It's just like, let's reflect, let's, how we're going to transform, how we're going to move. And at the end, these perspective shift involve deep engagement. Engagement in the dialogue is always very important. We sat, all of us, through these professional lapses, like talking to our learners. And sometimes we have the self-reflection is that, am I doing the right thing? Am I missing something? Or am I like being harsh? Or am I giving my learner enough time for them to realize what they're doing for them not to have another yellow card or like having another problem? I'm not going to talk about the study technically because I think Elizabeth was talking about that and Ethan also spoke about that. This is again a qualitative study, but there are a lot of food for thought for us as learners. And again, thank you again for sharing that.
So we're really tight on time. Leanne, do you just want to mention how few people have looked at this article? I thought that was fascinating that it had such a poor response on bibliometrics.
Yeah, it's fairly new. It was only published in October. It has been cited once, which is a little bit more than than the average for other articles of its age. But yeah, it doesn't seem like too many people have been saving it on Mendeley, which kind of implies that they're going to go back and read it and reread it or use it in their own studies. But it has been downloaded 483 times from the publisher's website.
Oh, really?
Yeah.
Because I was a little concerned, like people don't want to read about professionalism. So it's been downloaded that many times.
Yeah,
Okay.
six
Yeah.
of those were mine because I kept losing it and had to re-download it.
I downloaded it a few times too. Yes. I actually asked Ethan.
So
for-
between us, it was about 20 of them.
I just want to tell you, I put the eval form in the chat. You'll get it also from Barbara Sachs on response. Any feedback on this? It was a great, great session. We could be here for 2 hours to discuss this. We don't have that. I appreciate Dr. Shabate. I appreciate all of you, Dr. Fried, for this presentation to kick off the professionalism series. The next topic we're doing is in February, not related to the series, is looking at professional identity formation through our basic science curriculum, which is certainly a very important curriculum in medical education. And this is a great article. I have the author of this article leading this discussion. So just go back to the last slide, full screen. Any last comments by anybody? We're going to have a great session next time with a great discussant as well, Dr. Willie from the medical school. But any comments? And please,
Phil's got his hand up.
go ahead, Phil.
Yeah, I just wanted to comment that the discussion of the undermining of confidence and one's professional identity when being evaluated for professionalism, I think really underscores that when we evaluate professionalism, we're not judging people to be good or bad people. We're not inside their head and analyzing attitudes. We're really looking at behaviors. And the corollary of that is you can have a bad attitude, but it doesn't necessarily translate into bad behavior. And good attitudes don't necessarily translate into good behavior, as evidenced by the well-intended trainee who makes a misjudgment, who, makes that type of mistake. So I think that really is really emphasized in the article, and I think we have to realize that. And then the only other thing I wanted to just mention is be careful of the trainee who's an excellent communicator or is very socially adept. He may not always be professional, and sometimes we confuse that excellent communicator with being very professional when that is not necessarily the case.
Thank you. And I just want to say that I think this hours and hours you need to remediate professionalism is true. So I don't think this is a misrepresentation. I remediated a resident at Northwell, had a lot of issues professionally, and it took me hours. I met with him online at night when he was available, 8, 9 o'clock at night, because he was in a specialty that ran into that. And it worked, but it was hours of my time. And the program director was grateful, and she said she had nobody in the department that would spend that many hours remediating somebody. So when I was shocked by that, she said
And you can
nobody.
see how important that continuity is, and the follow-up and the true support. If they feel like they're being scolded, they're not going to respond. If they
Right.
feel like they're being supported over time, you've got a much better shot at it. And I think
And he really felt supported and was willing to then modify his behavior and understand why this was the case. And he didn't get off remediation the first 3 months. It took 6 months. And he did get off remediation and was able to progress in his training. So the truth is, this is a big job, and I thank everybody who's involved in it. So
and I thank you, Alice, for the opportunity to discuss this paper. Thanks so much.